Hi, my name is Dr. Ken Fujioka, and I'm at the Scripps Clinic in San Diego, California. This educational activity is basically about weight loss and pharmacotherapy, but we're going to teach you to leverage the tools that you have on hand. And the way we're going to do it is we're going to cover what are the recommendations, what do the guidelines say. Then we'll look at the current, but also some of the emerging pharmacotherapies. I wish I was a young man because the treatment options that are coming are amazing. And I don't say that lightly. For us to get 5 to 10% weight loss we thought was great. These newer ones are going to be over 15%. So again, the treatment options are really good, and they're really based on the hormonal changes that happen during weight gain. And then last off, we'll cover just some basic case histories of how you might want to look at treating a patient and coming up with a shared decision between you and the patient on how you want to approach weight loss. Let's move on to obesity. And I'm going to ask you to think about it as a chronic disease. And it has numerous causes. And for some of you, this may actually be a new concept because this was not taught this way in med school until very recently, literally the last not even 5 years. But in essence, there's unfortunately a very big genetic component. There's the environment, and then yes, there's behavior. So you got all three interplaying, driving up weight. What makes this a disease, though, is not so much the complications that come with obesity, and believe me, there are a lot of them, but rather the persistent hormonal and physiologic changes that fight weight loss. So in other words, somebody who gains weight, now their brain, the hypothalamus, the set point, is going to try and stay at that weight for the rest of their life. It never readjusts, which has been very frustrating, to say the least. So it becomes chronic. In other words, the body will always try and go back to that weight. But unfortunately, they also have all the problems that come with that increase in weight. When I first started in this field 20 plus years ago, we thought you walked into a room, you saw this food, you smelled it, and you turned on all these hormones that drove you to eat. Well, it turned out that was completely wrong. It's the exact opposite. Rather, if you look at that one that says NPY, neuropeptide Y, that's a part of the brain that's constantly turned on, driving you to eat. It's turned on all the time. When you eat a meal, then all these hormones that we have, GLP-1, PYY, amylin, leptin, they all go up into the hypothalamus and they're trying to get you to stop eating. So it's a very redundant system. And again, the drive to eat is one of the most basic, powerful drives we know of. And in essence, we're trying to turn it off. For those of you who remember back in med school, the biggest nerve that goes between the gut and the brain, that's the vagus nerve. The vagus, even though it has some fibers going down to the gut, most of it's going back up into the brain, telling the brain, hey, there's plenty of food, stop eating. And that combines with all the other hormones as well. Again, when you look at the gastrointestinal tract, food has to go from the stomach into the small intestine, into the distal small intestine, where you have these, what we call L cells, taste receptors. They can taste fat, they can taste protein, they can taste carbs. And when they taste those, they'll send up information telling you to stop eating. And the mesolimbic system is fascinating to me because it's very specific. So in other words, typically if you're turning on this reward center or crave something, it's actually a specific food. There's also a specific circumstance that will bring this on. So a good example of that would be, let's say that somebody, they work hard all day, they eat a pretty healthy dinner, but then they just sit in front of the TV late at night and now all of a sudden they crave chocolate or they crave chips or something like that. So that would be a typical reward system at work. And that's the one that is a little bit tougher to control. If we look at probably the most well-studied hormone that controls food intake, GLP-1, kind of walk through where it works and how it works. So you have NPY. This is again the part of the brain that's driving you to eat. Well, guess what? When you eat a meal and food gets in the small intestine tastes food and sends out GLP-1 into the blood system, that GLP-1 is going to go up into the brain and go to NPY and slow down eating. So it decreases hunger. But it also goes to POMC, which is the satiety part. So in other words, when you turn that on, you go, oh, I've got food around, stop eating. GLP-1 will trigger that. But here's the interesting part about GLP-1. Of the many gastrointestinal hormones that helps you stop eating, it works actually on other parts of the brain as well. The vagus nerve, biggest nerve between the gut and the brain, guess what? It goes there and it stimulates the vagus nerve at both ends, both up in the brain and down in the gut. Also, there are receptors in the reward system as well. So again, some of the reward eating will be decreased. Why is this such a chronic disease? Why is it so hard to lose weight and maintain the weight loss? And this is because of the following. So this was a study that literally changed my thinking, and it came out in 2011. And Sumitran and colleagues showed that they got a group of patients to lose 14% of their weight. And even at the end of a year, they were still down 8%. What surprised everybody, we knew in the first 8 to 10 weeks when they lost that 14% that they would lower their satiety hormones. In other words, they would literally be more hungry. They would literally not get as full when they ate kind of a standard meal because they had lost weight, 14%. But what we thought was at the end of a year, or in this particular study, 62 weeks, that the hormones would normalize. They would all get back up to where they should be and the patient would be fine and they could maintain the weight. Turned out we were very wrong. Because they were down 8.2% in their weight, the body had lowered all the satiety hormones. So they could eat the same meal they did back at day 1 or week 0, and they would actually not be as full. They'd want to eat more because, again, the hormones weren't coming up. So the body, the hypothalamus, had downregulated these hormones. And then the hormone ghrelin, it's the only hormone we know of that drives you to eat more, was actually higher than it was supposed to be. Meaning, again, that the brain is physiologically adjusting down hormones or adjusting them in the wrong direction, trying to drive back the weight. Another one is looking at your metabolism. And this is a tough one because it now tells you how important exercise is for keeping your weight down. Just your resting energy expenditure will drop about 15 calories per kilo for every kilo you lose. And that's just half of it. It turns out there's your energy you expend when you're exercising. There's the energy that your body expends when it burns food, all that kind of stuff. So that's only half the story. So literally it's 30 calories per kilo that you lose. So if somebody loses, say, 20 pounds, their metabolic rate is going to be about 300 calories lower than that same person who was also 200 pounds, but they were never 220. In other words, they were never overweight. And it shows you how hard this metabolic adaptation works to try and keep driving it back. And they actually followed some patients out to 6 years, and they still were doing that. 6 years. So very, very impressive how much the body wants to always maintain the highest weight it's been at.
Grooms loads a complete serving of fruits, veggies, adaptogens, vitamins, minerals, super mushrooms, prebiotics.
How do you approach the patient then that's overweight? What do you need to be thinking? What do you need to be doing so that you can give them the best possible care? And first thing is get a BMI. What's great is it's all over your electronic medical chart now. I mean, for us, it comes up as a vital. And as a matter of fact, if it's high, it's in red. But a BMI, and depending on the race, so you're overweight for Caucasian, African American, the minute the BMI is 25 or higher, 30, 40 pounds overweight. Now, there are some groups, particularly Asians, and it turns out they're overweight when they get to a BMI of 23. And the reason why is because of how they gain their weight. And people who gain their weight centrally, they get that visceral adiposity, and you can measure this by just getting a waist circumference. If their waist circumference is high, or they look apple-shaped, they're gaining the wrong kind of weight. So you get then this just huge laundry list of medical problems related to weight. Some of it is metabolic, obviously metabolic syndrome, type 2 diabetes, prediabetes, dyslipidemia, fatty liver, PCOS. This is all metabolically induced by this central fat that creates all these problems. But then there's the structural issues as well. The sleep apnea, the urinary stress incontinence, the osteoarthritis, GERD, all those other things that really get tough. And then the last one, which I think we forget about, is depression. I just want to show you the data of how striking it is when you start to get medical problems related to your weight. There's the Edmonton Obesity Staging Scale. And when you look at somebody, they can be 50, 100 pounds overweight, but they have no medical problems. They're doing fine. They're psychologically great. They're going to live just as long as anybody else. If you move down, they're starting to get a little bit down about their weight or their blood sugar is starting to creep up. Okay, now we've got some problems. But 2 is the one you typically see. As a healthcare provider, most of the patients we're getting that we're really worried about is the ones that have type 2 diabetes or prediabetes or dyslipidemia. Now all of a sudden they have established chronic disease that's related to their weight. So they're stage 2, then they're stage 3. That's your diabetic with neuropathy of the feet, starting to get end organ damage. And then there's the group that unfortunately I get. This is a group that's very severe. They're usually very overweight. They're going to have a lot of medical problems. They're oftentimes in wheelchairs because their joints are so bad and their weight's so high and they're just not getting around. Once they start getting to these higher stages with end organ damage, their lifespan is dramatically shortened. They're just on this trajectory going down. And if you look at the COVID-19 data that's coming out, it shows the exact same thing. Patients who are overweight, particularly with type 2 diabetes or uncontrolled blood sugars, really do poorly when they get COVID-19. But in essence, if they're healthy metabolically, okay, you don't need to be as aggressive. If they're starting to get stage 1, start thinking about diet, exercise. Definitely if they're stage 2, you need to really start thinking about weight loss medications, bariatric surgery. If they're 3 or 4, okay, you better do everything you can because again, we know if we're not turning things around, their lifespan is shortened. So we've assessed that they've got some medical problems related to their weight. We want to do something about it. What do? Lifestyle is always the core treatment option. You really need to think about treating the basic underlying behavioral issues. And this is tough. It's not easy. Let's start with the meal plan. The most important thing to remember is that it says individualized. And the reason why is all the studies show, and even the guidelines say, find what works for that patient. If that patient wants to do a keto, or they want to do intermittent fasting, or time-restricted eating, or a low-carb or a low-fat diet, let them. If they think they can follow it and it's reasonable what they're going to do and they're going to lose weight, do it. Find out what they want to do. Some patients you need to be very structured and say, okay, do a protein shake for breakfast, a protein shake for lunch, and have a regular dinner. Okay, that's all right. And other patients, and occasionally I get these where they need to lose weight very quickly. But generally speaking, I don't do that many super low-calorie diets anymore. That's anything less than 800. If you look at activity, it's real clear. They want to do aerobic and resistance together. In other words, they have to do them at the same time, but you really want both as part of their exercise routine, particularly for your older patients. Because as patients get older, particularly your geriatric group, say 65 and up, they need to be careful about losing too much lean tissue. And it can happen. Your standard person who loses 4 pounds, sure, they'll lose 3 pounds of fat, but 1 pound can be lean tissue. So again, you want to do some resistance training along with aerobic. It doesn't have to be a lot. It could be 20, 30 minutes, 2 or 3 days a week. That'll work. Sometimes you need to really start at ground zero. So you're just trying to reduce sedentary behavior because some folks spend way too much time just sitting and then we need to get them up and just moving. And that's okay. So again, you're looking at your individualized plan. And then there's all kinds of things you can do for behavioral interventions. Self-monitoring has been shown time and time again to be very effective, so that if they just write down what they eat, or if they're more techie, they want to do it in a cell phone app, that's fine. But if they do that, it's really going to help. But also self-monitoring of weight. It's really key that patients weigh themselves every day. Patients who weigh themselves every day do better in the long run for getting their weight down. Goal setting, patients want to, I want to lose 5 pounds a week. I want to lose a pound a day. Well, that's a little bit overreaching. So I'm just shooting for 1 to 2 pounds a week. You're doing well there. Education, counseling, I'm not really good at that, and I find most healthcare providers just don't have the time. So don't be afraid to use your outside sources here, especially for problem solving, social support, stimulus control, all that, again, comes in real handy using your commercial programs. Or I'll use folks that are within my own system, such as a dietitian who can really educate them on appropriate diet. Many dietitians are trained in weight management as well. How do you intensify? Let's say they're just not doing as well as you'd hope. You need to figure out, what can I do to turn things around? If I'm looking at, say, face-to-face contact time, just increase that. Just trying to see the patient, my standard 15-minute visit for 1 day a month. If I do that, you're doing good, and that's very reasonable. If you need to see more, which you might, again, use your outside sources. Use your dietitian. Use the commercial weight loss programs. If you have access to a behavioral modification specialist, these guys are great. They, generally speaking, are very good at just changing behavior. Not psychotherapy. They're not PhDs in psychology, although they can be. But a lot of times they're just your standard kind of coach or someone who's going to really guide them and try and keep them on track. You may have to structure their meals more. And again, don't be afraid to use a dietitian, but also you may need to say, look, you're making really poor choices for breakfast. How about if we just either skip breakfast altogether, have you fast until you get to lunch? Yes, it's okay to skip breakfast. The data is very clear on that. If we look at some of the recommendations, and again, there's tons of them. If somebody has failed standard lifestyle, sure, think about using medication. If somebody, again, and you're going to see this come up in all the recommendations, particularly patients that have a disease that's related to weight, whether it's type 2 diabetes, prediabetes, hypertension, fatty liver disease, all those numerous things, think about using a med, because we know that they're not tolerating their weight and that they're going to go on to medical problems relatively soon. And then if you use a weight loss medication, don't use it alone. Use it with diet and exercise or standard lifestyle changes, because you'll get twice as much weight loss.
Most people have no clue that in 2023, the best way to make money on Amazon is not with physical products. It's Amazon's other company.
So now we're going to switch gears a little bit, and we're going to talk about Know Your Tools, specifics regarding current and emerging weight loss pharmacotherapies. What treatment options do you have? So currently there's 4 approved for long-term use. There's Orlistat, which has been around for over 20 years. You got phentermine with topiramate, kind of an interesting combination of drugs. Another interesting combination, naltrexone and bupropion. And then there's liraglutide, the first of the newer treatment options that are going to be really hormonally based. If you look at the naltrexone, bupropion, and liraglutide, in essence, they've had these very detailed titration schedules of going up each week by this much. And if the patient is getting nauseated, don't increase. When I start them on the medication, I tell them, look, if you're feeling nauseated, don't go up on the dose. Stay at that dose until either you see me again or until the nausea goes away. Then go up on the dose to get to that therapeutic dose. Phentermine, topiramate, their escalation is really only 2. In other words, they start at this low dose and then go to the recommended middle dose. And if you look at the long run, the mid dose and the maximum dose really have pretty much the same amount of weight loss at the end of 2 years. All right, mechanism of action. So Orlistat, and I'll kind of cover some of the stuff we're going to see later on in terms of side effects, just because if you know the mechanism of action, then you understand the side effects. And basically, you're blocking the absorption of fat. So in essence, the fat will just run right through you, and then you can get the side effect of whoops, when you think you're passing gas, and it can even get what they call oil leakage. So again, it's just stopping the absorption of fat. Phentermine, topiramate, quite honestly, nobody really knows how topiramate works, but we think it works on the hypothalamus. In the hypothalamus, there are GABA receptors, and when you're modulating the GABA receptor in the hypothalamus, you can actually get patients to eat less. So it turns out topiramate works the way we want it to, in the sense of lowering food intake by working up in the hypothalamus. Phentermine is more, it basically lowers food-seeking behavior, if I could put it in any way, or lowers hunger or appetite. Now, naltrexone, bupropion, fascinating 2 medications that alone really don't have very good weight loss. But naltrexone works on the opioid system. It's an opioid antagonist, so it will lower some of that reward behavior of seeking food. But it turns out also that there's a part of the brain that the opioid receptor is involved with trying to maintain a higher weight. So it turns out that defense of staying at higher weight is actually, if you lower the opioid side of it, you can help somebody lose weight by that mechanism. And then last off, bupropion is strictly a dopamine norepinephrine reuptake inhibitor. So in essence, you're working on the hunger side of things. But you can also work on some on POMC and satiety. And then last on, liraglutide, or a GLP-1 agonist. We talked about it earlier in those earlier simplified drawings, but you're working at multiple levels, mainly because there's receptors for GLP-1 in so many parts of the brain. The average weight loss of these medications are going to be right around 8, 9, 10% weight loss. And don't expect one drug to work for everybody, but they have what's called responders. And so some patients do very well on one drug versus another drug. So this is just the average amount of weight loss. If somebody loses 3 or 4 or 5% at, we'll say, 3 months or 4 months, they're going to do well. But if we just look at the average weight loss, you can see they're all relatively similar. Liraglutide and phentermine, topiramate, clearly better than placebo. And even with naltrexone, bupropion, Orlistat, again, relatively weaker of the group in terms of weight loss. 8.8 still is not bad, but they have a fair amount of placebo weight loss, so it's going to be pushed up a little more. But to make a long story short, they're all going to get you at least that 5% weight loss. What you'll notice here is that the best of the drugs, liraglutide and phentermine with topiramate, almost 2/3 will get that 5% weight loss. So they're going to go on, they're going to do well. The naltrexone, bupropion, 48%, Orlistat, 51%, right around 50%. So a little bit lower, not huge, but a little bit lower. In essence, you're looking for that medication that works on that problem for that patient. And again, as we get to these better meds, you're going to see this really melt away, and these newer medications, because they're hormonally based, will work on multiple parts of the brain. And then earlier we said, whatever you do, when you give an appetite suppressant or when you give a medication for weight loss, you have to combine it with behavioral modification or with diet and exercise. Don't do diet and exercise alone, or don't do the meds alone, because you get so much better weight loss. If you just do the IBT or the behavioral therapy alone, you get 5% weight loss. But if you add naltrexone or bupropion, you all of a sudden get 9.3%. The same thing with liraglutide. If you just give the behavioral modification or lifestyle alone, 6.1%, you add liraglutide to it, you get 11.5%. Just dramatically much, much better. And again, you would expect that. When you think of weight loss medications, think of them as making it much easier to follow the diet. That's really what they do more than anything else. If we look at who loses 5% or more, you can see you driving those numbers way up, 78% liraglutide and 54%. All right, and moving on to the FDA approval contraindications or common adverse events. Orlistat, the only one that's hard and true is cyclosporin, which very few of your overweight patients are going to be on. And it's just the typical stuff that you can get some mild malabsorption. And side effects, pretty low, but they're, again, these GI side effects of oily leakage or oily spotting or steatorrhea, because that's what it's meant to do. The side effect of decreased absorption of fat-soluble vitamins, they just need to take their vitamins. So all of these drugs are contraindicated in pregnancy, and for good reason. The FDA doesn't want a pregnant woman losing weight. And even when I get some of these really tough patients of a woman who's very overweight and the OB says, hey, look, Ken, can you help me out? I just don't want this patient gaining any weight during the pregnancy because they're already too large. Then sure, I'll just maintain them, but I never want them losing weight. That's not good for fetuses. What makes phentermine and topiramate a little bit different is topiramate has been shown to be actually associated with cleft lip and cleft palate. So you really don't want a patient on that drug, and as soon as they find out they're pregnant, they should stop it. And personally, I don't give it to women who might even be able to get pregnant because I'm too worried about it. The side effects, insomnia, dry mouth, it does play with your taste, dysgeusia. And what it is anything that's carbonated, because topiramate is a carbonic anhydrase inhibitor, they will taste very odd to them. Naltrexone, bupropion. So it's interesting that bupropion, we don't think of it as being able to raise blood pressure, but it can raise it a couple of millimeters of mercury. So if somebody has uncontrolled hypertension, they shouldn't be taking this. The seizure disorder is also due to bupropion. A typical seizure rate might be 1 in 2,000. With this drug, it'll be 1 in 1,000. So it does go up. And if somebody is bulimic or an anorectic, bulimic meaning they purge, they should not be on this because the risk of seizure actually goes up. And then somebody who's got problems with alcohol and drugs, they shouldn't be taking because of the naltrexone component. Nausea, again, is by far the most common problem.
Yes, I said eggs for cholesterol. You can eat eggs, everybody.
Studies showing high cholesterol in people.
And then liraglutide, the only real contraindication is medullary thyroid carcinoma or MEN2 syndrome or acute pancreatitis. And that's for all the GLP-1s. And then again, the only real side effect, nausea. So again, that one you just need to titrate it very slowly, and you may not need a full high dose. So the FDA has really made every effort that they can to make sure that there's no cardiovascular risks related to the weight loss drugs that are available. And so you're taking literally over 10,000 patients with known heart disease and diabetes, and then following them either on placebo or on a medication all the way out to, say, 5 years and see who does better. So for liraglutide, they had very good data with their lower dose, the 1.8. And what they found is that patients did not only better than placebo, they did, we call a superiority test. In other words, they showed that they were better than doing nothing or not taking their drug. So that was fine. They're home free. They look good. With naltrexone bupropion, they ran into some problems when they did their cardiovascular outcome trial. They got about halfway through. There was no difference. They weren't any better, but they weren't any worse. But unfortunately, some of the data was leaked. So to make a long story short, they have yet to complete theirs. But again, halfway through, it looked safe. Orlistat, a whole nother ballgame, mainly because this was approved so long ago that this was before they had to show, quote, a CVOT trial outcome that was better or good or the same. And again, it's not systemic. This is just strictly works in the GI tract. They've had very good data up until now, so they're home free, they're doing well. The last one, phentermine topiramate, they've had to look at what's called post-marketing data. So they're looking at post-marketing data showing that they're as safe as anything that's out there right now. The FDA has really been on top of this, and I think, and especially as we move forward, any medication that makes it out is going to be very safe in terms of cardiovascular outcomes. Well, what do we got coming down the pipe? The latest thing is this FDA-approved hydrogel. This got approved very quickly because it's non-systemic, and it is a device, but it's used like a medication. The other two that are coming really soon, especially semaglutide, and then there's tirzepatide. You're going to see this kind of combinations of these gut hormones, GLP-1, GIP, all kinds of things, and you're going to see rather impressive weight loss. So this hydrogel, you're going to take 3 oral capsules and drink 500 cc's of water 30 minutes before lunch and dinner. What happens is these hydrogel particles expand. Patients are going to feel full, they're going to eat less, they're going to have less hunger. So it's working on a mechanical system. When this gets to the large intestine, then basically the pH changes, the water's released, it's reabsorbed by the colon, and then the remnants are just eliminated with the stool. Their weight loss is about 6.4% at the end of 171 days. If you look at the responders who loses weight, again, more than 5%, you're talking 2/3 plus are losing it, so clearly moving in the right direction. 37% may have a GI event versus in the study placebo group, it was 27%. So relatively low and safe. And again, they're just using normal food substances to make this stuff. Semaglutide is already approved for type 2 diabetes at 1 milligram once a week, and they've already shown improved glucose control. They've shown that they reduce the risks of a major adverse cardiovascular event, and these are again in very sick patients, type 2 diabetes with known coronary artery disease, so very safe, and matter of fact, better than doing nothing, which is to me huge. Typical weight loss in the diabetic trials, now these are not weight loss trials, is between 3 and 6.5%. And if you're comparing that to what's already out there, most of them are right around 2% in the diabetic trials. So they have a 68-week trial on patients on semaglutide 2.4. So this is well over double what we use for diabetes. 902 patients, so big trial. These are patients without diabetes. So this is a weight management trial. What did they see? Wow, 17 to 18% weight loss with this single drug trial. Side effect profile was just what you'd expect for GLP-1, nausea, GI side effects. So again, good to be young, good to be having these new things coming out.
Estrogen is killing men. In the next 60 seconds, I'm going to tell you all about this sneaky hormone and what you can do to stop it. So first off, what is estrogen? Estrogen is the primary female hormone that's stimulated by the brain into production that influences.
Let's move on now to coming up with a plan of attack. In other words, individualizing treatment. The patients themselves, they know they're overweight, and they probably have tried weight loss before, but they may have not lost all that much. But the scary part is if you look into your electronic medical record, you could have 100 technically obese patients or patients with obesity. Only 55% are going to walk away with a diagnosis of obesity in their chart. What's even worse is that only 24% will have any kind of scheduled follow-up to relate to that weight, to do something about it. So it means 75, 76% were missing the boat. What are the tricks of the trade when you're looking at communication skills with this group? Because believe me, you have to be careful about just the words you use. If you use the words like obese or fat, I can tell you you're going to make the patient very unhappy. So choose your words carefully. Use large or overweight, those would be much better. Trying to be positive rather than saying you're overweight and it's just making your blood pressure worse, well, that's not really positive. You could kind of spin it the other way and say, well, you know, we could do something about your weight, and if your weight comes down, your diabetes and your blood pressure would get better. Again, if you're not comfortable or don't have time, don't be afraid to use your outside resources. They're there. And believe me, most of them are pretty darn good. Be collaborative. Say, like, what can we do about your weight? sure goes a long ways. And keep in the back of your mind that up to 80% of somebody's weight is genetically determined. I mean, it sounds corny, pick your parents well. If somebody has one or two parents overweight, more than likely they're really going to struggle with weight. And then last off, be aware that larger patients need different equipment. So in other words, say something as simple as a gown. If somebody is seriously overweight, I'm not going to try and put them into a gown because I know they're not going to fit in it. So I'll just work around it, do the best I can on the exam. It's interesting to note that most healthcare providers are afraid to ask a patient about their weight because they don't want to make the patient mad. So it turns out the best way is just ask permission. Would you like to discuss your weight? Would you like to do something about your weight? And if they say no, just stop. Don't go on because you're just going to make things worse. But the patient will say, hey, you know what? That doc kind of respects me. Let's say the patient says, yeah, you know what? I really would like to deal with my weight. And believe me, 80% of your patients would love to talk about their weight. They'd love to try and approach it, do something. Even if it's just a referral to the weight loss center, they would be happy. Assess their weight. I would do it two ways. One is, what medical problems do they have? Do they have diabetes? Do they have prediabetes? Do they have sleep apnea? Because that tells you how aggressive you need to be. But also assess, why are they overweight? Is it, say, because they go out too much and get fast food? Or is it because they love to eat at night in front of the TV at about 9 o'clock before they go to bed and they're trying to unwind? It could be any one of those. So assess those two sides of the coin, the comorbidities and then the causes. And then advise, come up with some kind of treatment option, whether it's diet and exercise, why it's diet and exercise and meds, or maybe somebody who's tried everything. You need to really start thinking about bariatric surgery, and you may want to refer them over to the bariatric surgical clinic. Again, make sure you both agree on what are you going to do, because you may have somebody who is clearly seriously overweight, they got over 100 pounds to lose, they should go get bariatric surgery, but they don't want to do it. Don't do it then, because again, you'll go nowhere. Last off, a system. Help them out. They need help with diet. Use your dietitian. They need help with BMOD. If you can do it, great. Send them to a behavioralist. Send them to one of the commercial programs. They all do that. And we'll work, settle on a diet, settle on these things, and assist them and help them move in that direction. Telemedicine, it's clear it can work. We're just trying to figure out how to do it because, as you know, this was just thrown on us kind of within the last couple of months. And there are a few studies, not a lot. Here's a small study, 61 patients. Half did telemedicine, half did just kind of standard of care, really, not a whole lot of intervention. And they found that the telemedicine group actually lost almost 5 kilos, or about 5%. Standard of care didn't lose any weight, and they gained about a pound. So that was a 4-month study, small, but at least it's moving in the right direction. I live in San Diego, so we have just a huge number of computer scientists here. So these guys all want to do video conferencing, they all want to virtual, and you know what? It works. They don't have to leave work. They can do it right there in their office. Just find a quiet room, be on their own, and it seems to be the way of the future. Some of the other technology, which is really getting impressive. So the wearable device is a big one, and these are just maybe one of these wristwatches that calculates their activity, their sleep. They can even punch in what they're eating. So very, very amazing and very useful. The standard eHealth, which is using a web-based internet application. And again, it can be something where they get on the computer, and some of the patients seem to like that because it shows them all this tracking information. Mobile health, that's your standard smartphone, which can do amazing stuff, can track, again, just about everything. One, which I highly recommend, are smart scales, if you can get patients to use them. And the reason why is this: as I have switched more over to telemedicine, I worry about the accuracy of my weights that I'm getting from patients. And this is a way to get spot on for sure what their weight is. These smart scales will communicate directly with your electronic medical record, or it usually goes through their smartphone and then goes to your EMR system, but it'll track their weight. And again, the data is very clear. If you want a patient to lose weight, they need to weigh every day. But what you're looking for is trends, and knowing your weight and doing it regularly is very good at, finding out what is the trend, what's going on.
My new book, Keyboard Rich: How Anyone Can Earn 6 Figures from Home with a Simple Bookkeeping Business.
All right, so individualize it, get your weight history, find out what the triggers are, and then find out what's worked before, because you may be worth doing that again. And again, using all your treatment options, don't be afraid to use pharmacotherapy. The newer ones are just amazing and incredibly safe and better than doing nothing. And then look at your comorbidities. Clearly, there are certain comorbidities that you don't want to use certain weight loss medications with. And then find out what the patient wants. What do they want to do? And then monitoring their pharmacotherapy. All right, let's try a scenario here. Scenario 1. Insufficient weight loss on lifestyle management, but the patient is not really sure what do they want to do. Do they want to use a weight loss medication or not? So you have a 56-year-old woman, BMI of 28, and she has hypertension that's treated, so that's doing well. She's got prediabetes. So this is somebody you really want to keep their weight down because you don't want them to become a diabetic. And they're in a weight loss program, but over the last 3 months, they've been really stuck. They're on track. They've only lost a couple of pounds over the last 3 months. And she tries harder, but the question is, here's somebody who's already lost some weight, so now all the metabolic processes of lowering your resting energy expenditure, driving up appetite are all starting to kick in. Is this patient a candidate for a weight loss medication? She has a BMI of 28, she has comorbidity, so she would fit that. You can try some of your motivational interviewing techniques, which I'll be honest with you is tough to do as a primary care provider, but can be done. And then are there really any other options? And she's obviously not heavy enough for bariatric surgery, so maybe an appetite suppressant or maybe pharmacotherapy is an option for this patient. So this is somebody who has a lot going on. So they have multiple comorbid problems, and on top of this, they might be on a medication that's driving up their weight. So 68-year-old male, BMI 32, he's got type 2 diabetes, he's on metformin, A1C of 7.3. He's got established cardiovascular disease. So this is somebody who, by odds, is not going to make it to age 75, the average age at which most men die, because they've got a lot going on. Now, they're on paroxetine. So paroxetine, as you know, is a standard, very good antidepressant, but its side effect is weight gain. So we need to keep that in the back of your mind. And obviously, this guy's been told to lose weight, but he's not very confident in it because he's just not had good luck before. So what are your possibilities here? So there's actually quite a bit. And so there's an adjustment in medications. First off, could you use something other than paroxetine as an antidepressant? Use something that's not weight gaining, but really weight negative. You need to come up with a shared decision on what to do. Maybe you need to use a different or add on a diabetic medication that has a side effect of weight loss. Or heck, just go straight to a weight loss medication. That's another option. These are all treatment options, and you need to keep them all out there and see what he wants to do. All right, scenario 3. Patient is on a weight loss medication, but not getting the weight loss they want. 48-year-old female. This is a tough group because this woman is probably perimenopause. Things are starting to get tough now. As you know, when women hit menopause and perimenopause, they get this rather impressive drop in metabolic rate. Her BMI is 30, so she's, quote, obese. She has prediabetes. She's already on metformin. Hypertension is well controlled. She's been going to Weight Watchers, and she's on phentermine topiramate, and she's, over the last 3 months, has lost about 4 pounds. So there's a couple of ways to look at this. One is, if she has been on phentermine topiramate for 3 months and has only lost 4 pounds, and she started 3 months ago, then this is the wrong medication for her. It's not giving her the weight loss she needs. She's not what we call a responder. So you need to think about using a different appetite suppressant. If she's already lost a bunch of weight and maintaining it, okay, then you kind of look at it as, okay, she lost weight, she's maintaining it, she's doing okay, and this is about as good as I can do. Or you can start looking at other things. So one is she complying with her medications? Are there any things you can do to increase the intensity of the lifestyle? You know, quite honestly, I'm not sure you can. She's already doing Weight Watchers. You just need to make sure she's going. Okay, maybe we need to look at a different appetite suppressant, and that's very possible that she might respond to something else much better. So again, there's multiple ways of approaching this one, and this one is kind of a tough one. Looking at weight loss medications, they're clearly an option. They're a way of intensifying or helping out the weight loss, particularly when somebody's already doing the lifestyle modification. In other words, they're doing the diet, they're doing the exercise, and they're still struggling. And most of the available weight loss medications, they work much more specific now on targets. One might work on craving, one might work on metabolics, one might work on the homeostatic mechanism in the brain, the hypothalamus, particularly, again, these newer hormonal therapies. The available weight loss medications will give you about 5 to 10% weight loss. And again, you can get much better weight loss if you add on diet and exercise. The newer treatment options, yeah, you're looking at easily over 10% weight loss, which is just amazing. I mean, if you look at bariatric surgery, okay, 20, maybe 25% weight loss. But these newer medications that are coming down the pipe, I think you're looking at 15% weight loss on most of them, which is, again, to me, just so impressive. Last off, all the new medications are clearly going to have cardiovascular safety. They have to. The FDA is going to make them do these very impressive studies that are unbelievably expensive, very hard to do, but they're going to give you the answer. Is this safe over the long run? And then as healthcare providers, think of them at least as an option. And believe me, they have long-term safety, and think of them as chronic treatment. My name is Ken Fujioka, and I really appreciate you listening.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.